It's the first thing people see when they look at you, all right? And it is the largest organ in the body, all right? By surface area and weight, okay? And it's an organ because it's made up of different tissues, right? The epidermis is stratified squamous epithelial tissue, which is keratinized. The dermis, in the upper dermis, the papillary dermis is areolar connective tissue, and in the lower dermis, it's a dense irregular connective tissue. That's in the reticular layer. And the hypodermis, which isn't technically part of the integument, is made up primarily of adipose tissue. But running throughout all of these are nerve endings, smooth muscle, and we've also got immune cells running through here and a blood supply, right? So that for sure is an organ, okay? Dermal appendages include nails, which are basically keratinized stratified squamous epithelial tissue with more keratin really than the rest of the skin. The hair, which is produced by the hair follicle, which is pigmented, keratinized squamous epithelial tissue, right, stratified for both nails and hair. Sebaceous glands, which produce oils, okay, they are epithelial derivatives of the skin. And eccrine and apocrine sweat glands, the eccrine sweat glands are thermal regulators and are really pretty much throughout the body, with the exception of the genital regions. The apocrine sweat glands are in the axillary and the anogenital region. The eccrine are critical to life because they're thermal regulators and they help us balance our fluid levels. The apocrine really are optional because they produce a sweat that has a lot of fatty substances in it, which when bacteria act on it, produce body odor. Okay, so you could live without your apocrines. You couldn't live without your ecrines. The blood supply is papillary capillaries, and they are what keep the epithelial layer alive up to the point where we get to the stratum granulosum of the epidermis. And above that layer, the corneum is dead cells, which are shed into the environment everywhere you go. And in thick skin, like on the palms and the soles, there is lucidium between the corneum and the granulosum. And that is to provide for extra protection for things like grip and walking on surfaces, okay? Clinical manifestations of skin dysfunction, okay? Let's go through them. A macule is a flattened, discolored region. The papule is a raised, discolored region. A patch is a flat area of color change in the skin that's a centimeter or more wide. A plaque is a circumscribed, elevated, plateau-like solid lesion greater than a centimeter. A wheal is a circumcised raised lesion consisting of dermal edema. A nodule is a solid or cystic raised bump in the skin that's wider than a centimeter but less than 2 centimeters. A tumor is a growth of the body's own cells no longer under normal physiologic control. A vesicle is a thin-walled sac filled with fluid, usually clear and small. A bulla is a blister on the skin that's filled with clear fluid, often between the epidermis and the dermis. A pustule is a circumscribed elevated lesion filled with purulent fluid. That means that it's cloudy, less than a centimeter in size. A cyst is a benign, round, dome-shaped, encapsulated lesion containing fluid or semi-fluid material. Telangiectasia are visibly dilated blood vessels on the skin or the mucosal surface. Secondary lesions, okay, include scales, which are a visible peeling or flaking of outer skin layers. Lichenification, the skin has become thickened and leathery. The keloid, a firm rubbery nodule in an area of prior injury to the skin. The scar, the body's natural way of healing and replacing lost or damaged skin. Excoriation, which is a loss of epidermis and a portion of the dermis due to scratching or exogenous injury. A fissure, which is a linear, often painful break within the skin surface as a result of things like excessive xerosis, which is skin dryness. An erosion is an interepithelial loss of epidermis, usually heals without scarring. It's moist, it's circumscribed, usually depressed lesion due to the loss of all or part of the epidermis. An ulcer is a cratering sore on the skin or the mucous membrane, often bleeding. And atrophy is just localized shrinkage of the skin, which results in thin, wrinkled skin with easily visible vessels. Okay, so just some dermatological terms to know when we talk about these different diseases, right? Pressure ulcer. This is something you run into frequently in geriatric care. Okay, in patients that can't move themselves. Okay, they have to be turned periodically, or else the skin that lies over bony prominences will have its blood supply cut off and will begin to cavitate and be an avenue for infection, right? They result from unrelieved pressure on the skin, causing tissue damage. Risk factors are pressure, shearing force, friction, and moisture. Stages: non-blanchable erythema of intact skin, meaning it's red and the redness doesn't go away when you press on it, right? Second stage, partial thickness skin loss involving epidermis or dermis. 3, full thickness skin loss involving damage or loss of subcutaneous tissue. And finally, full thickness skin loss with exposure of muscle, bone, or supporting structure. Very dangerous, right? Suspected deep tissue injury results in discolored intact skin or a blood-filled blister. If it's unstageable, full thickness tissue loss with the base of the ulcer can be covered by slough or eschar, or both. Preventive techniques: assess the skin, reposition the patient, pressure reduction, removal and distribution, elimination of moisture. Okay, all of these are possible. The problem, of course, is that you're getting into the deeper layers of the skin and you're putting the patient at risk for infection because you're exposing those deeper layers. Keloids are elevated, rounded, and firm. They have claw-like margins that extend beyond the original site of injury. Hypertrophic scars are elevated erythematous fibrous lesions that do not extend beyond the border of the injury. Okay, by erythematous we mean reddened. Okay, both are caused by excessive collagen formation during dermal connective tissue repair. So this is something that is partially genetic. Okay, people overscar in some cases. In some cases, people will keloid on one part of their body and not the other. Right. So it's hard to explain why that is, but it is. Okay? Pruritus is just a clinical term for itching. Multiple stimuli cause this. It's associated with multiple primary skin disorders and systemic disease. Interaction with pain sensation is part of this. Unmyelinated type C nerve fibers transmit the sensation. Inflammatory disorders of the skin include eczema and dermatitis, which are the most commonly seen inflammatory disorders. They're characterized by pruritus, lesions with indistinct borders, and epidermal changes. So they itch. They have areas of reddening and thickening. Okay. When chronic, the skin becomes thickened, leathery, and hyperpigmented from recurrent irritation and scratching. Okay. Contact dermatitis is a T-cell mediated delayed hypersensitivity. The skin comes into contact with an allergen, binds to a carrier protein to form a sensitizing antigen. Langerhans cells process the antigen and carry it to T cells, which become sensitized to the antigen. Manifestations: erythema, swelling, pruritus, vesicular lesions. Okay. Erythema, reddening, swelling, edema, okay. Pruritus, itching, and the lesions, which you can see here in the inset. Inflammatory disorders. Irritant contact dermatitis is caused by activation of the innate immune system. The severity is related to the concentration of the irritant, the length of exposure, the disruption of the skin barrier. The symptoms are similar to allergic contact dermatitis. Atopic dermatitis, also called allergic dermatitis, is associated with IgE antibody. Remember that causes histamine release from mast cells and basophils. And there's a common history of hay fever, asthma with this. Okay, so again, with your immune system and with these inflammatory disorders, one of the things we have to recognize is that everybody's immune system is functionally identical, but structurally different, meaning it does the same job, but it's made of different pieces. And those different pieces are your your antigen binding specificities. All right. So everybody in the world has a kryptonite out there, but because your specificities are different depending on the way that your immune system was generated during education in the thymus and genetic recombination at the germline level, okay, for both your B cells and your T cells. Some individuals come into contact with their so-called kryptonite every day and have allergic responses, and some people don't, okay? There's also a genetic component to the number of mast cells and basophils that you generally have, and that has a role in this as well, okay? So this is one of the reasons that you have adverse events when you test a drug or a vaccine, okay, is that some percentage of the population will have a hypersensitivity to it because of the nature of the generation of our adaptive immunity, okay? Stasis dermatitis occurs in the legs as a result of venous stasis and edema. Sequence of events: erythema, reddening, pruritus, itching, scaling. Petechiae, what are those? Those are ruptured capillaries, okay? Hyperpigmentation and ulcerations. Seborrheic dermatitis is chronic inflammation of the skin involving the scalp, the eyebrows, the eyelids, the ear canals, nasolabial folds, axilla, chest, and back. You can see this in cradle cap in infants, which is tinea capitis, right? It's a fungal infection, and scaly white or yellowish plaques that result. Papulosquamous disorders include psoriasis, which is a chronic relapsing proliferative inflammatory skin disorder caused by complex interactions between macrophages, fibroblasts, dendritic cells, natural killer cells, T helpers, and regulatory Ts. Okay, so to review real quick, macrophages ingest incoming pathogen or antigen and present it on the surface to the T cell population. The T cell population that recognizes these presented antigens is going to be activated when it binds to it, right? The helper T is included in this. And the result then is that we activate via the T helpers those cytotoxic Ts, and natural killers, and sort of hybrid cells that are going to go out and do this damage, all right? So the T helper is a link in the chain here. The regulatory T is the population that's supposed to turn off the T cell mediated effects. And if it's not working the way it should, then you can end up with conditions like psoriasis, okay? It shows evidence of dermal and epidermal thickening. The epidermal turnover goes from 2 weeks to 3 weeks to 3 to 4 days. So it's much more rapid. Cells that don't have time to mature adequately keratinize. There's a silvery appearance. Types include plaque psoriasis, inverse psoriasis, cutate psoriasis, pustular psoriasis, and erythrodermic psoriasis. Okay. Pityriasis rosea, okay, it's characterized by a herald patch followed by scaly oval patches in the trunk and proximal extremities and a Christmas tree-like appearance. Pityriasis rosea means rose-colored scale. This disease is an acute self-limiting papulosquamous disorder characterized by a herald patch followed by scaly oval patches on the trunk and the proximal extremities. It is also called Pityriasis cerencinia, roseola annulata, and herpes tonsurans. Okay, the skin eruption is usually 6 to 8 weeks after the herald patch appears. Okay. Papulosquamous disorders also include lichen planus. It's a benign autoimmune inflammatory disorder of the skin and the mucous membranes. T cells, adhesion molecules, and inflammatory cytokines, as well as perforin and antigen-presenting cells are involved. Is linked to numerous drugs and hep C virus. It results in non-scaling purple-colored flat-top polygonal pruritic papules and oral lesions. Pruritus is the most distressing symptom. You itch terribly, okay? Acne vulgaris is an inflammatory disease of the pilosebaceous follicles. Acne rosacea is an inflammation of the skin that develops in adulthood. The lesions are erythematologiactic, papulopustular, and phytomous, and ocular. They're associated with chronic inappropriate vasodilation resulting in flushing and sensitivity to the sun. Okay. Our next one is systemic lupus, and we're interested here mostly in the manifestations that are going to take place in the integumentary system.
Welcome back to Sansamed. In the following video, we're going to talk about systemic lupus erythematosus. So let's just divide first the words and then describe it. Systemic refers to that it will affect your whole body. Lupus will refer to that you will get a wolf-like face. You will not become a werewolf, but you might get some abnormal appearances. And erythematosus because it will affect your blood and its vessels. SLE is an autoimmune disease. You will see it mainly in female African Americans and Hispanics in their reproductive years. So why is it females mainly? It's actually a 9-to-1 ratio between males and females. You will see it mainly in females because females are able to be pregnant. And what's the correlation? Because they are able to get pregnant, their immune is usually downregulated at the time of their menstruation and their pregnancy, and therefore it's easier for an autoimmune disease in general to affect a human. What is important to know about SLE, its signs and symptoms, is essentially the site with high blood flow are the main targets. So you will see how will it affect the brain, the kidneys, the skin, and many other organs. But practically it can actually affect any organ. As many other autoimmune diseases, there are always a target antigen. In SLE, the target antigen is the nucleus, and therefore there is a production of antinuclear antibodies. But this is not specific because ANA are seen in many different autoimmune diseases, and therefore we cannot assume if somebody has a positivity in ANA in their lab work that they have SLE. The special components of the one that has the highest specificity is the double-stranded DNA. The normal nuclear DNA is the major target, and it's the most specific one. But it can also be against histones, RNA, SMIT gene that is a part of the ribonucleoprotein family. It can even affect your phospholipid membrane and other specific components such as cardiolipin that is found in the mitochondrial membrane, or even the blood components. We'll discuss all of them briefly in a short while. It has its association with both type 2 and type 3 hypersensitivity, and as we describe the signs and symptoms, we will see how they are correlated. What you need to mainly focus on is that it's mainly a type 3 hypersensitivity due to its immune complex formation, the antigen and antibody in the circulation. It has shown some association with some complement factor deficiency, especially C2 and C4. So what can be causes of SLE? There isn't a single specific cause, but there are multiple factors that will be involved. It can be environmental. Environmentally, this can be due to a high level of sun exposure. That would explain a little bit why it's more frequent in African Americans and Hispanics. But it can also be due to exogenous pathogens, such as certain bacteria and viruses. But it can also be some genetic factors. The one that they usually associated with is some subtypes of major histocompatibility complexes, class 2, specifically MHC, DQ, and DR. There are even occasions where you can get SLE by some drugs you take. If you have some moderate hypertension, the doctor might prescribe to you a drug called hydrolysine. This drug can work as a hapten. Hapten is essentially a non-working molecule that can bind to a tissue and induce inflammatory reactions. These reactions will give similar signs and symptoms as SLE. That's why the drug hydrolysine can induce SLE or SLE-like symptoms. Other drugs that can do the same is procainamide, which is an antiarrhythmic drug, or even isoniazid, which is an antituberculosis drug. Clinically, what would we see on people that have SLE? would see something called flares and remission. Flares refers to periods of illness, and remission it will be recovery or rebuilding. So this is not always a constant process. This will have its ups and downs. So let's start talking about its signs and symptoms. But one of the major rules that we have to always think about is, as it's a part of type 3 hypersensitivity and its immune complex formation, it usually affects your vessels. As it affects your blood vessels, it will induce inflammation, so we will call it vasculitis. And in the inflammation, there might be several events of thrombosis, which would cause ischemia. So one of the major keywords in SLE will be ischemia, and we'll see why. So let's start with the signs, symptoms, and criteria. One thing you might see is a discoid rash. Due to decreased blood flow to your skin, there might be a formation of some skin patches because the skin doesn't have its nutrients, and therefore the skin might pale off a little bit and form a discoid shape. And eventually, this can even lead to scar formations. This is usually seen in head areas, in the forehead, for instance. Also, due to ischemia to your mucus or even skin, cells will not get their nutrients. These will start to die out, and this will lead to ulcer formations. And usual sites of this are in the mouth area, so you will have some oral ulcers. You can also see photosensitivity, essentially that you're sensitive to light. And this brings us back to one of the environmental factors that can induce SLE. So you will start to get more skin patches and different ulcers and scars, usually on the face. SLE can also induce arthritis. Arthritis is essentially joint inflammation. This can affect any joint, but it's usually more specific to hands and wrists. But although there is excessive inflammation in your joints, this usually does not cause cartilage destruction. So the problems of arthritis will not be that severe if you would compare it to another autoimmune disease such as rheumatoid arthritis, in which the cartilage would be damaged and cause permanent damages. One of the things you usually associate with SLE is malar rashes. Malar refers to butterfly shape, and this is usually seen on cheeks and nose. And the cause of this is essentially the same as discoid rashes due to decreased blood flow, and also due to the fact that the immune complexes can sometimes deposit between your skin layers, between your epidermis and dermis, and cause blister formations on the face. The immune markers that we usually see are anti-histone antibodies, anti-double-stranded DNA, anti-Smith, antiphospholipid membrane, cardiolipin, and blood components. The ones that you should remember mainly is the anti-double-stranded DNA, because this one is the most specific when you refer to SLE. But if the SLE would be drug-induced, such as you remember, hydralazine, procainamide, and isoniazid, in this case, the usual antigen is the histone. So the antibodies are mainly focused on histone. As you remember from basic physiology, your brain and head requires a lot of blood. So, of course, one of the major affected areas is your brain. So, as there will be decreased blood flow to your brain, this can cause ischemia. There are many neurological problems that can be caused by this ischemia. The most commonly seen in SLE is headache, but it can also cause other problems such as psychosis, anxiety, depression, and many more. As SLE constantly causes inflammation, one of the things you will see in any inflammation essentially is an elevation of erythrocyte sedimentation rate, abbreviated ESR. This is essentially the sedimentation of your red blood cells in 1 hour. As you remember, your kidneys gets 20 to 25% of your total cardiac output. And when you have kidney diseases in connection with SLE, we prefer to call them lupus nephritis. Lupus nephritis can cause many different conditions. This is a very big topic, but we'll just briefly cover that. There are 3 types of processes that are involved: diffuse, focal, and membranous lesions. In this video, we'll just mention that what will happen clinically. Clinically, you will see painless proteinuria and hematuria. So you will see a certain amount of protein and blood in your urine. But as this causes many other different kidney problems, you will see other conditions such as glomerulosclerosis, thickening of your glomerular membranes, and it can lead to other diseases such as nephrotic syndrome. And you will also, of course, see, since this is a kidney-related problem, you will most likely see hypertension. All of this can eventually lead to renal failure. As you remember, what you will mainly see in SLE is anti-nuclear antibodies. And if you do a test about it, you will see positive values of anti-nuclear antibodies. SLE can also go to your serous membranes. And which are your serous membranes? The easiest way to remember it is the triple P: your peritoneum, your pericardium, and your pleura. And we'll take an example of pericarditis. You can assume that if the pericardium is inflamed as it surrounds the heart, it will affect your normal heart contraction because it will now compress your heart. When it affects the pleura, it can cause pleural effusion. When it affects your peritoneum, it can cause abdominal pain. SLE can essentially decrease all of your blood cells. When it decreases your red blood cells, we call it anemia. This anemia is also one type of a group of anemias called autoimmune hemolytic anemias. This will fall under our type 2 hypersensitivity in the first subsection, which is opsonization by cellular depletion. Here you will see that the antibodies will attach themselves to your red blood cells, and when your red blood cells will pass your spleen, they will get stuck in the Billroth cords, and then your splenic macrophages will catch them and digest them. So this will cause a decrease in red blood cell number. And in anemias, you will see different signs such as weakness and paleness. If there is a decreasement of your white blood cells, we call it leukopenia. And you can assume if you have a decreased amount of white blood cells, you're going to be more prone to infections. It can even affect your platelets. The autoantibodies can come and bind to your platelets, and they will get stuck in the Billroth cords of the spleen and eventually causing the macrophages to digest them. This is seen in a condition called immune thrombocytopenic purpura. And here you will see other signs and symptoms such as nose bleeding called epistaxis and prolonged menstruational bleeding, and also an increase in duration of the bleeding. And this is a condition we call menorrhage. So how can we remember all of these signs and symptoms? We can make a simple mnemonic, and the simplest that we have found is dopamine rash. This will cover most of the diagnostic features that you will see in SLE. We can also see sometimes a condition called Lippmann-Sachs endocarditis. This is essentially that the autoimmunity will affect your bicuspid and tricuspid valves, and this will cause vegetations. In this picture, we see a summary of everything we spoke. What are the causes of death and treatments in SLE? As you remember, by its hematological problems, decreased level of white blood cells increases the chances of infections. So if it increases the chances of infections, it will increase mainly the infections that you would normally not get when you're healthy. And these are the types of infections we collectively call opportunistic infections. The similar types of infections are also seen in AIDS patients. So what can be an example of these opportunistic infections? It can be angio-invasive aspergillosis. Another cause of death is end-stage renal disease. So this is another name for renal failure. And there are many conditions in renal failure that can cause death. Another way of death is by pulmonary hemorrhage. So why is that? Sometimes the antibodies can bind to loads of your pulmonary alveoli. If this occurs aggressively in a short period of time, so essentially acutely, it can cause pulmonary hemorrhage. If this problem would occur for a long time, this can eventually lead to pulmonary fibrosis. And the problem with this is that since your right ventricle supplies the lung, the right ventricle now needs to work a lot harder. And as a result of this, it will enlarge and eventually fail. So this is a condition called cor pulmonale. In SLE, you can also get certain lymphomas, such as non-Hodgkin. Cerebral infarct can be due to multiple thrombosis that you might get in your cerebral vessels. You can also get thrombosis in your deep veins, usually in the lower limb, and we usually abbreviate it DVT, deep venous thrombosis. And this can result eventually in pulmonary embolism, which will cause pulmonary problems. So what are the treatments for SLE? We can use corticosteroids. And the reason for this is essentially by using different types of steroids, by their anti-inflammatory properties, they will decrease the formation of antibodies, which are the major factors that play a role in SLE. We can also give people immunoglobulin therapy. And by this, we mean that if you would give loads of immunoglobulins to the SLE patient, their splenic macrophages has a receptor called FC receptor. They will get flooded. So they are now busy. Since they are busy now, they cannot digest your own blood cells. And that will help with leukopenia, anemia, and thrombocytopenia. These are usually collectively called pancytopenia. Another way of treatment is splenectomy, essentially removing your spleen, because spleen is the site of the hematological problems. And of course, if you can use corticosteroids, you can also use immunosuppressive drugs. So by suppressing the immunity, you will have less antibodies. But this can also be a cause of death, because if you depress the immunity even further, you can increase the chances of opportunistic infections. So what is the final outcome of all of this? SLE, of course, it can be fatal, but it has actually very good prognosis because this is usually seen in its early stages, and therefore it's highly treatable. An example of this is the 20-year survival rate is usually more than 75%. And hopefully now you know more about SLE. Thank you.
Vesiculobullous diseases include pemphigus, a rare blister-forming disease of the skin and oral mucous membranes. It's an autoimmune disease caused by circulating IgG autoantibody. Remember that IgG and IgM are the only antibodies that are found in blood. The antibodies are against the cell surface adhesion molecule desmoglein and the suprabasal layer of the epidermis. Immunofluorescence demonstrates the antibodies at the site of blister formation. This is one of the ways they know, right? Types, pemphigus vulgaris, an autoimmune painful sore and blister on your skin and in your mouth. Pemphigus vegetans, autoimmune heaped up cauliflower-like vegetating plaques in the flexures. Pemphigus foliaceus, generally a benign variety of pemphigus. It's an autoimmune skin disorder characterized by the loss of intercellular adhesion of keratinocytes in the upper parts of the epidermis, resulting in the formation of superficial blisters. Pemphigus erythematosus, an autoimmune acantholysis and immunoglobulin deposits in the interkeratinocyte substance. Paraneoplastic pemphigus, a rare autoimmune disease that's almost always associated with confirmed occult malignancy. Patients typically present with painful and extensive mucosal and cutaneous involvement with poor prognosis. IgA pemphigus, a rare autoimmune blistering disease caused by painful and pruritic vesiculopustular eruptions. They form as a result of circulating IgA antibody against keratinocyte cell surface components responsible for cell-cell adherence. Pemphigus herpetiformis, a rare subtype of intraepidermal autoimmune bullous diseases that associate the clinical characteristics of dermatitis, herpetiformis, and immunologic features of pemphigus. Okay? So you can see all the different examples there. Erythema multiforme. It's a syndrome characterized by inflammation of the skin and mucous membrane associated with T-cell immunologic reaction to drugs or microbes. It's caused by immune complex formation and deposited around dermal blood vessels, basement membranes, and keratinocytes. A bullseye or target lesion is a symptom, central erythematosus region surrounded by rings of alternating edema and inflammation. It hits the mouth, the air passages, esophagus, urethra, and conjunctiva. Severe forms include Stevens-Johnson syndrome, which is a bullous form, and toxic epidermal necrolysis. Bacterial infections, folliculitis, infection of the hair follicle, furnicles, inflammation of the hair follicles, carbuncles, collections of infected hair follicles, cellulitis, infection of the dermis and subcutaneous tissue, erysipelas, acute superficial infection of the upper dermis, impetigo, superficial lesion of the skin caused by coagulase positive staph or beta hemolytic strep. Okay. Herpes simplex, okay, include HSV1 and 2. They're transmitted by contact with infected saliva, associated with oral infections or infection of the cornea, mouth, and oral labia. This is for HSV1. Lesions for HSV1 appear as a rash or as clusters of inflamed, painful vesicles. Genital infections are more commonly caused by HSV2. Okay, now remember, the herpes class are the type that integrate and never leave. Okay, because they can get into host DNA as integrated genetic material, or they can live in the nucleus as independent genetic material. Okay? And then this is herpes zoster.
Post-herpetic neuralgia, in contrast to diabetic neuropathy, most commonly manifests as mononeuropathy, meaning the condition affects a single nerve root. The herpes zoster virus causes chickenpox, but also remains dormant in the body's dorsal root ganglion cells once chickenpox has subsided. The herpes zoster virus can reactivate at some later point, causing shingles. Why the herpes zoster virus reactivates in a specific person is rarely understood. However, known causes include immune system depression and other CNS conditions, including stress, hormonal changes, or nerve injury. When herpes zoster reactivates, it inflames dorsal root ganglion and infiltrates dorsal root neurons. This inflammation hinders dorsal horn cellular metabolism. In particular, it impairs nerve conduction and pain transmission. The herpes zoster also targets the peripheral segment of the dorsal root ganglion. The virus travels from the dorsal root ganglion to peripheral nerves, causing shingles characteristic rash. Once in the peripheral nerves, herpes zoster can cause peripheral demyelination and fibrosis.
So this stays resident in your body for your whole life if you end up contracting the chickenpox. Okay, there's a vaccine for it now that's routinely taken, but before the advent of the vaccine, we would typically purposely expose children to zoster to get chickenpox in their infancy or in their youth, so that it wouldn't manifest itself in the adult. Okay, because when you get the zoster, you develop natural active immunity to the virus. Warts are benign lesions caused by HPV. Common warts are often seen in children, usually on the fingers, while plantars are on pressure points on the bottom of the feet. So these warts actually grow into the sole of the foot. Condylomata acuminata are venereal warts, okay, in the anogenital region. Okay. Fungal infections always are preceded by the word tinea, okay? They can cause superficial skin lesions and are called dermatophytes. Fungal disorders are called mycoses, which are caused by dermatophytes and termed tinea. Tinea capitis on the scalp, mantis on the hand, tinea pedis is athlete's foot, tinea corporis is ringworm, tinea cruris is jock itch, tinea unguenum is toenail fungus, also sometimes called onychomycosis. Candidiasis is caused by Candida albicans, which is on us, innocent, around us all the time. Okay, it's normally found on the skin, the mucous membranes, and in the GI tract and vagina. Candida can range from a commensal organism to a pathogen. Risk factors: local environment of moisture and warmth, systemic administration of antibiotics, pregnancy, diabetes, Cushing's disease, debilitated states, often presents in ages younger than 6 months, immunosuppression, and neoplastic disease. Vascular disorders. Cutaneous vasculitis is an inflammation of the blood vessel wall resulting from immune complexes in the small vessels. It can develop from drugs, allergens, or viral infection. The lesions include palpable purpura, progressing to hemorrhagic bullae with necrosis and ulceration. Sorry. Necrosis, of course, is tissue death. Okay. All right, let's pause here. We'll take 15. Erythema, edema of the superficial dermis associated with type 1 hypersensitivity, so it's an allergic response, and its reaction to allergens. Histamine release causes endothelial cells of the skin to contract, making leakage of fluid from the vessels occur. Most lesions resolve spontaneously in 24 hours, but new lesions may appear. Okay. Scleroderma can be localized or systemic. It's a thickening of the skin associated with several antibodies. Localized scleroderma is different from the systemic form of the disease by the absence of sclerodactyly, Raynaud's phenomenon, abnormalities of the nail bed capillaries, or internal organ involvement. Okay. So the CREST acronym is used to describe this. Okay. The skin is hard, hypopigmented, taut, shiny, and tightly connected to underlying tissue. Progression to body organs can occur. All right. All right, let's talk a little bit about Lyme disease, right? This is a multisystem inflammatory disorder caused by the spirochete Borrelia burgdorferi, transmitted by Lixides tick bites. Symptoms of the disease occur in 3 stages: localized infection, disseminated infection, and late persistent. Okay. Essentially what happens is that the bite introduces the spirochete into the blood. It moves through tissues in a corkscrew-like motion, tagging tissues with decoy antigen, which then distract the immune system as it destroys really uncompromised tissue, okay, producing damage. The spirochete is able to escape, right? And eventually, once we get the spirochete, we can end up, as a result of interacting with these decoy antigens, generating autoantibody and producing autoimmune disorders months after the initial infection. Benign tumors, an example, seborrheic keratosis in here, benign proliferation of cutaneous basal cells. Keratoacanthoma, benign self-limiting tumor of squamous cell, differentiation from hair follicles. Actinic keratoses, premalignant lesions composed of aberrant proliferations of epidermal keratinocytes, and nevi, which are moles, which are benign pigmented or non-pigmented lesions. Okay. Now, anytime we're talking about a tumor or a skin cancer, okay, we're talking about the causal agent being mutation. Okay. Skin cancer is generally named for the layer that it occurs in. Okay. Example, basal cell carcinoma, the most common cancer worldwide, with numerous subtypes, grows slowly, develops crusts, and is firm to the touch. Metastasis is rare. All right. Squamous cell carcinoma is in the epidermis. It's the second most common human cancer. It can be in situ or invasive, and rarely invades surrounding tissue. Okay. The big one is melanoma. Okay. Malignant tumor of the skin originating from melanocytes and has the ability to metastasize and can be mistaken for a mole or a nevus. Okay. Which is why you have to check your body all the time for changes in the mole or the nevus. And you've probably heard the ABCDE way of determining whether you've got something that's potentially cancerous. Okay. Let's see if I can get this up here for you. So ABCDE, right? A is asymmetry. B is irregular border. C is multiple color. D is diameter, okay? And E is evolution over time. Right? If you see any pigmented areas that are doing this, then you want to go into your dermatologist or your GP and have it looked at. Kaposi sarcoma is a vascular malignancy associated with immunodeficiency, such as in AIDS or in chemo or radiation treatment. Associated with herpes virus 8, it generates pruritic, painful, purplish brown lesions. Okay? Cutaneous lymphomas are where cutaneous T cell and B cell lymphomas are present in the skin without evidence of extracutaneous disease at the time of diagnosis. They develop from clonal expansion of B cells and T helpers, and rarely T suppressors. One of the manifestations is mycosis fungoides. Okay. All right, burns. Okay, burns are classed according to the depth of damage. Okay, first degree burn is epidermal only with local pain and erythema. It's very painful. Okay, like a sunburn. Second degree, superficial partial thickness, epidermis and some dermis. Okay, deep partial thickness, epidermis and dermis, leaving only skin appendages. And in second degree, you often see blisters, okay, which form between the epidermal and dermal layer. Okay. Third degree, full thickness burn, epidermis, dermis, and underlying subcutaneous tissue are all affected. Fourth degree, full thickness and deeper tissue, epidermis, dermis, and underlying subcutaneous tissue, tendons, bone, and muscle are involved. Total body estimation uses the rule of nines, which divides the body surface area up into multiples of 9. And you can estimate how serious the burn is. If greater than 20% of the total body surface area is burned, it's considered to be a major burn injury, right? So you can see the front of the trunk is 18, the back is 18. The whole head would be 9%. The front and the back of the upper arm would be 9%. The upper arm and the forearm. The front of the thigh and leg would be 9%. The back would be 9%, and so on. Okay. Associated with massive evaporative water loss and fluctuations of large amounts of fluid, electrolytes, plasma proteins into the body and tissues, and burn shock. Okay, the cardiovascular system results in decreased cardiac contractility and decreased cardiac output with inadequate capillary perfusion. Why? You've lost a lot of fluid volume. Fluid and protein movement out of the vascular compartment results in elevated crit and white blood cell count and hypoproteinemia. Irreversible shock and death can occur if we don't treat it immediately. Capillary seals are one of the things that occur in these types of burns. The cellular response, transmain potential disruption, impairs the sodium-potassium pump. We see increased intracellular sodium in water, decreased potassium. Metabolic response in the flow phase, systemic hypermetabolic response. It can persist for up to 2 years following the burn. Inflammation with local activation and recruitment of inflammatory cells at the site of injury. Hypermetabolism increases the thermoregulatory set point and the core skin temperature. Okay. Immunologic response, immediate, prolonged, and severe. The end result is immunosuppression, altered white blood cell profile, impaired phagocytosis, abnormal cellular and humoral immunity, potentially fatal wound sepsis, right? That's one of the big ones is if you're getting down into the deeper tissue, you're exposing the blood supply to the outside world, sepsis can result. Evaporative water loss, right? Loss of the skin's barrier function and ability to regulate evaporative water loss. The skin and the lungs have increased water loss as a result of hypermetabolism and hyperventilation. Replacement is mandatory, okay? Complex prolonged recovery and complications occur with major burns. The goal is debridement and closure in a manner that promotes survival. Scar formation with contractures is often a consequence of healing deep partial thickness and third degree burns. elements of survival of a major burn, provision of adequate fluids and nutrition, meticulous management of wounds with early surgical excision and grafting, aggressive treatment of infection or sepsis, and promoting thermoregulation. Basically, you're trying to compensate for all of the functions of the skin that are now missing, right? Here's a scar contracture you can see, right? As scar tissue forms using a contracture of the tissue, okay? So we can see here the flow chart, right? You get the acute burn injury, direct tissue injury and increased capillary permeability, leading to edema and systemic injury response, okay? That leads to tissue ischemia and more tissue injury, resulting in acidosis, depressed cardiac function, and multi-organ dysfunction. Endothelial injury, leukocyte sequestration, tissue injury, leading again to acidosis, depressed cardiac function, and multi-organ dysfunction. Systemic injury response, we see an increase in capillary permeability, which can lead to hypovolemia and hyperviscosity, resulting in tissue ischemia and all of the end effects that we've already noted. Okay. Here's an example of hypertrophic scarring. Okay. Cold injury, right? Skin injury caused by exposure to extreme cold usually hits the fingers, toes, ears, nose, and cheeks, where circulation is minimal. Okay. Frost nip is cold exposure without tissue freezing and is reversible. You see skin pallor and numbness. Chilblain is violaceous skin color with plaques or nodules, pain, and pruritus without ice crystal formation. Frostbite occurs when the tissues freeze with ice crystal formation. Numbness and no sensation of pain until thawing, then severe pain, and it's classified again by the depth of injury. Flash freeze is rapid cooling with intracellular ice crystals associated with the contact with cold metals or volatile liquids. Now, again, we have to appreciate the fact that when ice crystals occur, you're rupturing the cell, okay? It's one of the reasons that living things often die when they freeze, okay? Disorders of the hair, right? Alopecia is loss of hair from the head or the body. Androgenic alopecia is the result of men inheriting the baldness gene from their mother because it is a sex influence trait, and the elevated testosterone levels then allow expression of the trait. Okay, it's androgen sensitive and androgen insensitive follicles that result in the pattern that you see. Okay, female pattern alopecia is progressive thinning and hair loss over the entire scalp. There's no loss of hair along the frontal hairline, unlike in the male. Okay, now can women experience male pattern baldness? They can. Okay, but they would have to get two baldness genes, one from their mom and one from their dad, and they would have to have abnormally high testosterone production. Okay, I've seen some women with male pattern baldness, and it's very unusual when you see it. Okay. Alopecia areata is an autoimmune T-cell mediated inflammatory disease against hair follicles that results in hair loss, while hirsutism is basically excessive hair growth, okay, and unusual distribution on the face, the body, and the pubic area in a male pattern that occurs in women, okay? There are androgen sensitive areas. There is a genetic component to this. Disorders of the nail. Parenchyma is acute or chronic infection of the cuticle, while onychomycosis is fungal or dermatophyte infection of the nail plate. And what you get is a raised or thick